Janet McClaran. This is Soft Tissue Surgery Journal Club. This is being recorded, so you can read this at any time. And if you are not listening live, please do feel free to email me or call with any questions that you might have about anything that we discussed today. We try to have journal clubs every 4 to 6 weeks in different disciplines in order to share the latest in what's out in the literature depending on the discipline. So for this month's journal club, decided to highlight some recent articles that have been published about cholecystectomy, which, as we all know, is removal of the gallbladder. So just a really quick background on surgery of the gallbladder when it's indicated, a brief photo of anatomy just to remind everyone what's involved with considerations anatomically. The regional anatomy is important in surgical considerations and complications that may happen during or after surgery. I did highlight here the shortfall or downside of most of these articles, as they are all retrospective studies. There's something to bear in mind. There's a lot of interesting information, but in general, not a lot to help us with some of the important decision making, unfortunately. So the reason why the complications are being highlighted is because there is a relatively high mortality and morbidity that's associated with these surgeries. So depending on the study you read, there can be intraoperative mortality rates up to 40% of the cases. And so usually this is because of intraoperative bleeding and hypotension at the time of surgery. But again, the considerations for postoperative complications include pancreatitis due to the regional anatomy of the pancreas being so closely and intimately associated with the bile tract. Certainly, if there is a complication for suture, staple, or insufficient sealing of the common bile duct, there is a chance that these cases might require revision surgery and bile peritonitis could occur. If the gastrointestinal tract is open or entered for catheterizing of the common bile duct, then potentially there's a theoretical complication of dehiscence or peritonitis from the gastrointestinal tract as well, although that seems to be a less common consideration or concern. So one of the things that a lot of these studies try to kind of parse out is when is surgery indicated, and things are a little bit different in dogs and cats. The majority of these articles are about dogs, but we'll highlight one feline article as well. Certainly we know when emergency surgery is required, that's a bit more obvious. So when there's leakage of bile into the abdomen, and that's something that we can ascertain by doing a paired bilirubin of any abdominal fluid and comparing that to the systemic blood work, then we'll know that there's a risk for bile peritonitis. If we have evidence that there's biliary obstruction, so that's something that can be ascertained by looking at elevations in our total bilirubin. Also ultrasound evidence or imaging evidence of biliary tract obstruction. And usually these obstructions are caused by a reason other than pancreatitis, because pancreatitis is something we generally would give time or medical management to resolve. But if we do see that there's any neoplastic disease, any cololiths or calculi or the biliary system, parasitic disease being quite a bit more or less, a bit less common, a bit more obscure. And of course, which we'll go into, is biliary mucoceles. That timing becomes more complex because if there's not leakage of bile, it's hard to know when we should intervene with surgery. At the first sign that the animal has a mucocele on ultrasound, or when they start to show clinical signs of disease, or when their total bilirubin parameters change. So this is what a lot of the articles try to give us answers to. So a brief overview and review of the anatomy of the common bile duct that sits between our quadrate and right middle liver lobe, or right medial liver lobe. The anatomy is a little different in people and dogs, and that's why surgery is a little bit more straightforward in people. There's less of a it's easier to access and remove the gallbladder in people than it is in dogs, and that's why it's something that's done so much more commonly. But to review, your gallbladder sits there and drains into your cystic duct, and then all of your hepatic ducts drain into your common bile duct, which then enters the duodenum at the major duodenal papilla. So when we're removing the gallbladder, that's done here at the level of the cystic duct, and we need to make sure that these hepatic ducts are flowing and able to drain the bile from the liver system into the intestinal tract. If there's a blockage of the common bile duct, then we look into things like diversion techniques, where we reattach the gallbladder to the intestinal tract in a cholecystoduodenostomy or cholecystojejunectomy. That's a little beyond the scope of what the papers cover today, when we're talking mostly about disease of the gallbladder itself that necessitates removal of the gallbladder at the level of the cystic duct. So things to consider in surgery, as we talked about, we have to ensure that the patency of the common bile duct is intact before we can remove the gallbladder. We also want to make sure that we have a durable seal on the common bile duct. So vessel sealing devices are commonly used, but very controversial. There's some evidence to show in porcine or pig models that, unfortunately, the vessel sealing devices do not give us enough of a durable seal to allow us to be confident that a vessel sealing device alone is enough to seal the common bile duct. So in general, the recommendations are that we either staple or suture in addition to using vessel sealing devices, rather than relying just on vessel sealing devices. Always good to make sure we have culture results and submit all our samples for histology to make sure we're treating underlying diseases that cause the initial congealing of bile and hyperplasia of the abnormal structures in the gallbladder. And again, often liver biopsy is helpful and indicated to give us more information to guide future therapy. And abdominal drains and feeding tubes are useful when we have actual rupture and bile peritonitis. So again, the first few articles are general reviews on the overall retrospective findings of dogs that undergo cholecystectomy for gallbladder mucocele. So the first study we'll go through is a 2013 vet surgery article that's a retrospective review of 43 dogs. And the goal was very general, just to assess prognostic factors that might impact upon outcome. The downside of this study is that they did not report any hypothesis, so it was a general review in order to try to ascertain information about whether or not there were any prognostic factors that could help decide or help us guide owners to give any idea of prognosis. So really, these dogs had about 37% of them had evidence of bile leakage at the time of surgery, but they didn't really find any preoperative or intraoperative findings that had any impact on survival, which is a little bit disappointing. They did find that animals that had post-operative hypotension or post-operative changes in their lactate or PCV were less likely to survive than those that had less problem with hypotension or anemia or hyperlactatemia. Again, that's less useful because those factors were only analyzed, or only post-operative factors rather than preoperative factors. So in terms of how well this paper did in assessing prognostic factors, it was not very helpful. So they did not identify any preoperative or surgical prognostic factors that impacted on survival. And they didn't necessarily find that there's any correlation between dogs that had necrosis and leakage of bile and overall prognosis. And they found the only thing that was quite interesting and useful in my mind was that they had a pretty low mortality rate. So overall, only 7% of patients died within 2 weeks of surgery. So the overall results were promising. So that's good to know that there's not necessarily the death sentence, even with ruptured gallbladders in this particular study. Potentially, we can try and avoid hypotension, which I guess we would do anyway, but it doesn't necessarily give us a lot of information about what we can look for beforehand to pick our cases. So I would say this one, less useful to study. Moving forward, next study gets a little bit more useful because we have twice as many dogs. So it's a retrospective of 70 dogs. And they again looked for 2 cohorts of animals. So they looked at emergency and elective cholecystectomies for the treatment of gallbladder disease. And they hypothesized that those patients undergoing elective gallbladder removal would have a better prognosis than those requiring emergency surgery, which is fairly intuitive, but also good to have an actual retrospective study. So they had about 64% of the dogs that received elective cholecystectomies and 40% that had urgent or emergent surgery. And they did find, as you might suspect, that the dogs that had elective or planned surgery had a significantly lower complication mortality rate, 2%, rather than those that require urgent or emergency surgery. And I think this probably echoes our experience that if we are able to catch the dogs before they become quite ill and require emergency surgery, then we have a better chance of a good prognosis. Overall, again, the trend in all the more recent studies is that the survival to hospital discharge is better than previously reported. So in this study, only 10% of the dogs, rather than the up to 40% of dogs, failed to survive to hospital discharge, which is quite promising. And they did show, again, pretty intuitively, the dogs with clinical signs such as vomiting, anorexia, lethargy, and icterus were more likely to die rather than those dogs without clinical signs. Similarly, the higher the ALT and bilirubin and lower albumin also seems to have impact on outcome. They tried to look at whether or not flushing of the common bile duct at surgery was a significant factor, but again, elective cases were less likely to have their gallbladder flushed, so that's something that we have to interpret with caution. So we can't really make any judgments about flushing of the common bile duct, but it does seem in the study that dogs with clinical signs, blood work changes, and those requiring emergency surgery appear to have a better outcome than, a worse outcome than dogs that had less urgent and were more stable prior to surgery. So this again suggests the benefits of early intervention, which I think from a clinical perspective seems to ring true. And then the last kind of retrospective and very useful study looked at actually a fairly large cohort of dogs. So 121 dogs were included in final study. They actually initially looked at records from twice as many of cases, but then they were eliminated because of incomplete medical records, which is unfortunate, but also a problem with retrospective studies. So they also aimed to compare both elective versus emergent surgery, but also to kind of parse out a little bit about catheterization technique and whether or not that affected complications and mortality. The background there being that we'll sneak preview of how surgery is done in people laparoscopically for dogs and dogs that are stable that have laparoscopic surgery and people, they never catheterize the common bile duct because that's very difficult / impossible to do laparoscopically. So they wanted to look and see if there was any impact on catheterization on outcome as well. And they had a pretty firm definition of non-elective or elective cases based on the presence or absence of clinical signs. Certainly emergency cases were those that had gallbladder rupture, biliary tract distension, and those that had clinical signs or blood work changes. So in this cohort of patients, the mortality rate was significantly lower for dogs, so just low 6% for dogs that had elective surgery, and about 25% for the dogs that were requiring urgent or non-elective cholecystectomies. Not necessarily that they had ruptured gallbladders, but that had clinical signs or signs of blood work changes requiring them to have surgery on a more urgent basis. The dogs that actually did go ahead and have gallbladder rupture had a significantly higher mortality rate of 33%. Important to recognize that even for elective surgeries, there is a fairly high rate of complications, although most of those are minor. Some postoperative complications, gastrointestinal regurgitation, minor incisional complications. But it is important to notice that there is a fairly high morbidity, even though the mortality was lower than previously reported. But in general, this was a much better case series. So I would say of all the studies, I was most impressed with the high case numbers and the really detailed case information that was provided. And so I think it's a good resource to go back and look at this paper just to get lots of information about the types of cases requiring surgery and some of the details about the surgical types. Their second hypothesis was not able to be achieved, so they were not able to determine whether or not catheterization techniques had an impact on survival. They did say that more studies are required to determine if there's an association with having open your duodenum and retrograde flush the common bile duct, and whether or not that had a higher rate of complications. Again, unfortunately, the dogs where the common bile duct is flushed, where you do a duodenotomy and open and flush the common bile duct, are generally the cases that have more severe disease. So it's really difficult to determine if it was that the cases were more severe or whether the gallbladder was flushed, and how that led to complications. So I apologize for this next paper. It just appears to be available in abstract form only, or abstract form only. So more to come when this finally is published in print form. For now, it is just an abstract online. It's a retrospective review of looking at serum C-reactive protein concentration levels and whether or not that was an important determinant for whether the gallbladder is ruptured. So traditionally, we determine if the gallbladder is ruptured in dogs by using ultrasound. In people, they do ERCP, so they're actually able to go in with a scope into the duodenum, and then they are able to catheterize, retrograde catheterize the common bile duct, and they can then use contrast agents or scintigraphy to determine if the gallbladder is ruptured. That's fairly invasive and not very easily achievable in dogs. So because we know that ruptured gallbladders appear to have a worse prognosis, this group tried to look and see if CRP concentrations were significantly higher in dogs that had a ruptured gallbladder compared to the dogs with an intact gallbladder. And they did find that the CRP concentrations were significantly higher. So something to watch this space. So in terms of sensitivity, it was 100% accurate, 100% sensitive rather, and slightly lower specificity and accuracy. So something to look for in the future. Again, they said it was a useful tool, but really was best used in conjunction rather than to replace imaging. So it was useful, but not necessarily superior to abdominal ultrasound. So, and then I just want to take a brief little timeout to make sure we all paused and try to remind ourselves about what that means: sensitivity, specificity, and accuracy. So I put this down here, and no doubt we'll all have to look it up every time because it's one of those things that as many times as we learn it, we unlearn and forget it. But just as a reminder, a test sensitivity is really often the most important thing because it measures how often a test generates a positive result for people who actually have the condition. So it measures true positives. The specificity is how well a test rules out a disease process. So it measures a test's ability to generate a negative result that is appropriate for people that don't have the disease. So how well is it able to rule out disease? And accuracy is a little bit less useful. It doesn't necessarily give information about positives and negatives, but it lets us know how well the test is designed. Is it measuring what it is meant or intended to measure? The statistician seems to rely on this accuracy less frequently, but good to have a timeout and remind ourselves what these tests and phrases mean. And then finally, the last two studies, just to give a little other perspective. This is a study that looked retrospectively at 20 dogs that had laparoscopic cholecystectomies. Again, as I mentioned, this is the treatment of choice in people. I will mention that it was only 20 dogs and it was multi-institutional retrospective study. They wanted to assess for complications and the number of cases that required conversion from laparoscopic to open surgery, and also to look and see if those cases that required conversion to open laparotomy had a higher rate of complication. This unfortunately was not a hypothesis-driven study. So they literally just kind of reported that we did this in 20 dogs, so a little bit less useful. They did find that of their patients, 30% of them required conversion from laparoscopic to open laparotomy because of their inability to get good ligations around the cystic duct. In 2 patients, they had evidence of tearing of the gallbladder and the cystic duct respectively, and 1 patient suffered cardiac arrest intraoperatively, so they were able to revive that patient and convert to an open laparotomy to continue their procedure. The good news is, again, echoing from the other studies, is that all dogs were discharged from the hospital. They reported that they all had resolution of clinical signs, although they don't follow all of these patients long-term, unfortunately, and they did find that there were some complications, including pancreatitis in 1 dog, and also a dog that did have leakage from the common bile duct following surgery and did require repeat or revision surgery. So, and unfortunately, there's significant case selection bias, because certainly you pick the most stable and less clinically affected dogs when deciding which dogs are going to be appropriate for surgical candidates laparoscopically. So for these dogs, these cases, they actually did not include any dogs that had persistently high bilirubin levels, any evidence of any clinical signs, any evidence of gallbladder rupture, effusion, any kind of adhesions, anything that looked like the dogs were actually obstructed. So they can't really give us any valuable information on what cases are best, except to say that in this cohort of very stable dogs, they didn't have a very high rate of complications or intraoperative mortality. So interesting, they did have a cardiac arrest in 1 of the patients. The amazing seems to be that they were able to revive that patient and continue. I guess this does give us the information that if we're going to pick patients for laparoscopy, even if they are stable without any blood work changes or any evidence of gallbladder rupture or abdominal effusion, that about 1/3 of those patients are going to require conversion to an open surgery. So it's good to prepare the operating theater and staff for that possibility, as well as to let owners know that the conversion is a possibility. And that does echo previous studies on minimally invasive surgery. That does give us the information that even though we had to convert some of these cases from laparoscopic to open surgery, that doesn't necessarily lead to more complications for the patients. So finally, a little review of the feline patients that undergo cholecystectomy, a little bit of a different cohort. So gallbladder mucoceles are less of an issue. For kitty cats, actually the most common indication for cholecystectomy in cats is cholelithiasis rather than mucoceles, but I thought I'd include this because there's not a lot of information out there on cats undergoing cholecystectomy. They did hypothesize that in the absence of neoplastic disease, cholecystectomy may be associated with a better outcome than previously. A lot of the previous studies do show a very high mortality rate. So the mortality rate, up to 40 to 50% of patients not surviving through surgery versus dogs. And there was a previous study that looked at neoplastic disease of the biliary tract in cats. And actually those cats had 100% morbidity. So excluding patients from neoplasia, hopefully we report a better than previous prognosis. So they did look at a small cohort, again, 23 patients that had cholelithiasis. And the good news is about 3/4 of them, 75 to 78%, did survive to discharge. There was a very high rate of perioperative complications, so that's important to let the clients know. And again, unfortunately, there about 21% of patients did not survive to hospital discharge. The good news is, of those patients that did survive to discharge, their long-term evaluation based on client and owner survey was considered excellent. So the thing to take from this case, I thought, was how challenging the anesthesia was. So the interesting bit is that the cases were a very long time frame. So we're looking at almost 20 years ago for some of the previous cases, which may explain some of the challenge of the anesthetics, since we've certainly progressed since that time frame. But it's important to know that almost all of the cats had intraoperative hypotension recorded. So it's really important to be prepared for intensive management for hypotension. And also there was a very high rate of transfusion, anemia, and transfusion with plasma or oxyglobin, which shows how long ago this study started, as well as auto transfusions are something that was pretty common. So 14 cats were anemic and 9 of them required transfusion. So helps us to realize that while the prognosis is better than previously reported, we do need to be prepared for a potentially challenging anesthetic experience and the need to have blood products available. So, but again, overall, it did give us the positive information that those cats that survived through surgery, that in 6 months, 83% were still alive, and about half of the patients, almost half the patients, surviving for 3 years. So that's kind of a whirlwind summary of what's out there in the surgical literature for gallbladder disease, mostly in dogs, but a little bit in cats. And I would say the overall conclusions, summary, and take-home messages is that the timing of surgery seems to be controversial, but as we might expect, if we can intervene before patients are ill and before their gallbladders rupture, that seems to be associated with a better prognosis. And if we can intervene earlier, there may be more minimally invasive or laparoscopic options available to us. Certainly being prepared for complicated anesthesia cases, especially in cats, having treatments for hypotension and blood product availability and at your disposal is important. Hopefully, by being prepared and knowing your anatomy, you're going to have less of an anesthetic time and potentially a smoother surgery. So important for you to be prepared before surgery, and also preparing owners appropriately for the potential complications of bleeding, pancreatitis, peritonitis post-operatively. And really, I would say this kind of echoes a lot of the other literature in veterinary medicine, is that given that most of these studies are retrospective rather than prospective, case-controlled clinical studies, that we are limited in what kind of information that we can gather from the literature. So I don't think there's too many people live that are wanting to ask questions, but certainly we do accept cases at London Vet Specialists for gallbladder surgery, and I'm happy to be contacted here at the practice of London Vet Specialists by email or by sending through any referral if you do have questions about whether or not your patients would be good candidates for surgery. So thank you for your time, and again, I'm happy to answer any questions if they arise. Thank you very much.